Probably notable of some of the stuff that Matt was saying earlier around the GMT or cost reports that you go on the Medicaid level. I know a lot championed that over the last few years. And we're finding out that a lot of the consultants that advised on the GMT, they were what we were calling impermissible costs. That's why the OIG has come back and said, states, you're in trouble. You shouldn't be allowing these costs. Cost reports have been around since the 70s. Hospitals have been doing cost reports for years on data, but technically CMS is only allowed and Medicaid is only allowed to pay for direct patient care. And so when you start putting stuff into cost around non-direct patient care, then that becomes a problem. And the reason why I'm bringing that up is now we have data coming in. And so our industry's been asking for data. And so I think most in the room, who's all provided their data in the last few years? Almost everybody. There's a reason you've been doing that. And now we're going to starting to see that stuff come out. So the first release of the data that CMS did that started to use some of that data that you came out was released at the end of July. And so I'm going to talk through some of that data. We expect the second release to come out towards the end of this year, early next year. You're going to start to see some of the data that people want to dive into. Like, I want to see what the costs are by different areas, things like that. You're going to start seeing a little bit of that. You're not going to see CMS opine on what should happen. That is going to be the Medicare Payment Advisory Commission's responsibility. They're going to go back. We're on that second half of it. We do know that they're going to get something. We are hearing from some of the MedPAC commissioners that more than likely the end of next year, we will see a MedPAC report on what they should do with the ambulance payment system. So I'm going to start talking a little bit about that. I think we have a runway. There's some things that are starting to come out in the data that's a little concerning. The industry needs to be aware of. There's some good things as well. And so I'm going to talk through some of that. So raise your hand if there's a question, but I'm going to walk you through some of the data. And then I'm going to start drawing a correlation to the last MedPAC report that we've ever had as an industry, and that was in 2013. So that was about 11 years ago. And it's a very interesting, unique correlation that you're going to start to see. And I'm going to do a very in-depth webinar on that towards the end of the year. So stay tuned. That comes out next week. So actually, if you're not on my listserv, no, because I'm going to do a correlation between what the data is starting to tell us and what MedPAC advised Congress back in 2013. And I'm going to tease you a little bit about some of the data as I walk through it. Okay. I'm going to talk a little bit more about, you're going to hear my next presentation, but we do a lot here at Solutions Group, but I'll talk about that later. Let me move through quickly to where we started. Does anybody know, how many people know that CMS sent the first pass of data? It's okay, if it doesn't matter if you have, are you aware of it? Okay. How many actually read it? Okay. Some people's eyes probably just glossed over because it is a lot of information. It's like, what does this really tell me? So I'm going to tell you through the lens of reimbursement. But there was two reports that they sent out. One was called the organization's entrance and exits. What they meant was how many ambulance suppliers entered the market, how many left the market, and then there was another analysis that they did by looking at the Medicare fee-for-service claim data. So I'm going to draw you to some highlighted points that you need to pay attention to as we go through there. There were 5 analyses that they conducted in the first report of the entrance and exits, people that came into the market and people that left the market. They actually only looked at those providers who billed Medicare. Okay, so if you did not bill Medicare fee for service, you are not included in the data. That is a very important point to note. So if you're looking at it at the state level, you've got ambulance providers still operating who do not bill Medicare. Okay. So understand that concept. So when the regulators look at things, they're looking at it through the lens of who actually bills the Medicare program. What is the expense associated with that? So real important to know. Two is they also talked about the share of the ambulance providers that exited the program. They actually categorized it into certain organizations. They looked at it by 4 different characteristics. Provider supplier. Remember, a provider is hospital. That's the easiest way to remember it. Most of you in here are probably going to be what we would call a supplier of ambulance service. And then you're looking at the ownership structure. Pretty self-explanatory. Your service area density, I'm going to talk a little bit about that. I think that's that urban, rural, super rural, but there's a very important point to note that's a little different than other healthcare specialties. And then they talk a lot about volume. And this is where I think is eye-opening to the industry And there's a reason why some of us aren't doing this on national platforms right now. We're doing it very concerted because there's certain things that are in this report that we have a runway. And there are some people, unfortunately, that have people listen that are regulators to their stuff, and you don't want to tip them off on certain areas that we might have concerns ourselves and let them find it themselves. Does that make sense? So I'm going to ask when you do send this out, there's probably some slides I'm going to take out and then you can distribute, okay? There's 4 and number 5. I don't really care about number 4. There's a lot of predictive analytics that people do. People like predictive analytics, but to me, it's just you're just predicting what you think is going to happen in 5 years from now. I'm okay with that, but let's just say what the data is telling us right now, because there's a lot that can change in our industry over the next 4 to 5 years. But it's an interesting thing if you want. I'm not going to talk much about it, but I am going to talk about number 5. And this is the estimated county level regressions that predict county level changes in transport volume. This is very important to know. I think this is a win for the industry. We've been talking about, we're very local, very county based, very city based, and they're beginning to recognize it. Now, we may not like all the data that's going to start coming out. Some people are going to be really happy in the industry, and some people are going to be like, oh crap, it's now down to the county level. So this is the area when we say that healthcare is local, EMS is local. Some people say when you've seen one EMS system, you've seen one EMS system. Not sure I really believe with that. But technically, you're telling people it's very localized. The data is coming out that way, okay? And they're going to start looking at it that way.
Does that should it read estimated county level? Because it says country level.
Oh, does it say country? You know, that is my, thank you for looking at that. It's
I
county
just
level.
wanted to make sure.
That's the first one that I've done, and I've presented that. Yeah, we will put it's estimated county level data. Good thing we'll make a note here. Here's the one thing that did note, and this is a misnomer. We hear something in the industry a lot. There's a lot of ambulance suppliers leaving the industry. I'm not doubting that. It's anecdotal data, but the data does not show that. Very interesting over the last 5 years that you pretty much see the same number of people filling the Medicare program over a 5-year period. So from 2017 to 2022, you saw a marginal change in MPI numbers that build the Medicare program. And so we hear a lot of stuff where people are saying stuff, but remember what people are looking at when they're looking at the data. Does it back up what you're saying? It might be very county level, might be very regional specific, but is the data bearing claim to what we've been saying? This is what data is going to start to tell us. And this gives us time to rethink our talking points. And we might have to say, well, hey, we're seeing a major issue in just Eastern Colorado is having a problem, not the entire state of Colorado. Does that make sense? Here are the key takeaways. You that have read it, I'm just going to give you the key takeaways that you need to pay attention to. 93% of all ambulance billing billed in subsequent years. What that means is if you billed in 2018, you also billed in 2019. So technically, 93% of all ambulance providers billed the Medicare program in subsequent years. They did not exit the market. There was a 7% that entered and exit, and it was almost an equal split between who entered and who exited. So very important, I'm going to break that down for you. Those that actually exited, I don't think this is any surprise to anyone, is that more than half of who exited the market was for-profit companies. All right, and for-profit companies in urban areas, if you like that. Okay, and they also entered the market the quickest. The interesting thing that the second largest, and we think we know what this issue is, even though they didn't really opine on it much, the second largest was nonprofit. And then when you look at who entered the market, of course, it was for profits. Government agencies entered the market more frequently. And that is an issue with a lot of the volunteer organizations. You know, we started to have a lot of issues with volunteers. COVID hit, workforce shortage issues, a lot of volunteer labor, a lot of the volunteer organizations that bill Medicare per bill as nonprofits. And when they left, we could feel that there was a stopgap that came in for the governance. Okay. So some of that is related to that. And interesting when you look at the dynamic, when you look at it, pay attention to how they're lumping you in right now in your ownership. You're either a for-profit government or you're a nonprofit. Okay. There's a lot of classifications that they put into to try to do subclasses. Just notice how they're lumping people in. Your service area density, your rural, super rural, urban. Remember how we bill in EMS when they're looking at claims data. That is not where you reside as a practice location. That is where you pick a patient up. Very key to note, because this is an area we've got to make sure we do a lot of education on. So some of the data that's coming out is painting a picture that we know is not accurate. And we know it's got to be tied down, that we have to tie the NPI numbers to actually where you're based. So you might be an urban-based provider stationing ambulance units in a target in a very rural area that's picking up patients, okay? Volume is, I'm going to opine on volume here in a minute. That is probably our biggest area that we have concerns with as an industry. The only thing that I'm going to do about a regression analysis that I'm going to actually opine on that I think you need to pay attention to is what I put at the very bottom, that the more volume you do, the less likely you are to exit the market. Okay. And the more volume providers you do, the less likely you are to enter a market, because there's going to be a lot more competition. You're going to be looking at that from a different level. And remember, it's for profits that enter or exit. Okay. And so when government comes in or out, generally what we see is that governments are less likely to enter compared to their for-profit counterparts, but they're less likely to exit. So when they decide to come in, they usually do not leave. A few things here that we do know is a problem with the data around where you pick patients up, and this is on the rural, super rural, and super rural organizations. So super rural organizations were less likely to exit in the data. So they saw that, we don't see a lot of that. And that kind of contradicts a little bit with what we're hearing with some news reports that are happening anecdotally across the nation that are indicating we don't have this deserts, we have all these ambulance deserts or whatever. So what's causing that? What we see probably happening is the NPI number once we get it to the practice location. So there is some data analysis that is happening to contradict that right now. That's actually taking the data from the NPIs that have been registered in PACOS and basically now correlating it to the data that we're starting to see come out to show the disparities, that if you look at it like you do physician practices, ambulance surgical centers, health, hospitals, what does that look like compared to what they look like? And so that'll be more of a representative picture. So that's going to be an error. We're going to have to use data to kind of counteract some of what this is saying, or when the MedPAC report comes, they're going to have to be educated on what the problem there is. This is an area, before I get into the next piece of it, that I want to just make sure people understand. Data is just data. It's just a window. It is incumbent upon us to paint the picture of what we look like as an EMS industry. We've been asking for the data. We have been saying something. There are going to be some pivots that we're going to have to make because it doesn't substantiate. The data is not going to substantiate what we've been saying over the many years. And so we're going to have to take a look at that. But we have some time as this stuff starts coming out. Where do we need to be on the offense? And remember, MedPAC just makes recommendations. And we were able to dispute and defeat some of the recommendations that came out in 2013. But now they have data. And when you start looking at the report that they did in 2013, they admitted they had anecdotal data. Basically, they just had a lot of data from survey studies that were done with the Government Accountability Office, things like that. But now we've got a bigger picture of data. And we also know that 50% of the ambulance suppliers of that number did not submit their data. For some reason, a lot of small providers. And they decided to take the penalty. So that tells you whatever that reason was, we didn't want to do the data. So we paint a picture in people's minds when you don't submit it as well. You didn't ask for a hardship. You were given every ability. I remember getting the and say, but what are the numbers for? What can we do? And that's why you saw at the last minute, people at the last minute were needing it. They were pretty much giving you any waiver you wanted. We had some providers that waited. They got a change in their fiscal year. Their fiscal year normally was calendar year, January to December. They changed their fiscal year to be December to the following to give themselves more time. CMS was giving a lot of leeway for you to get in there because people were not providing data. So you paint a picture when you don't provide the data. And so a lot of the data that's going to start coming out right now, we know is going to be about 50% of the ambulance providers that were sampled. What do you need to pay? And this is the one reason why I'm really not talking a lot nationally yet about this. I'm going to talk one-on-one because I think there's some issues that we have in the data. And it's very glaringly obvious when you look at it. And this is when you get down into the Medicare fee-for-service claims. And when you actually look at the data, there's some of us that have been doing this for so many years. And in 26 years that I've been doing ambulance on the reimbursement side, it's the first time I've seen a report come out on some certain things. So I'm going to highlight that. I'm going to talk about that. I think that is a problem and a product of some of the stuff that we've done in the industry, because Well, if the claim got paid, it must be correct. And now you're beginning to paint a picture that I'm going to correlate to what MedPAC found in a finding. And they actually made some recommendations. And it's going to start to, people start to have aha moments. Like, I see what's happening now. And so we have a time to make some corrections and some changes. But there were three main sources of data that they looked at. One was Medicare fee-for-service. Duh, you're talking about Medicare fee-for-service claims. Of course, you're going to be pulling Medicare fee-for-service. Here's the other thing that a lot of us kept talking about: update your pay codes. Make sure you're updating your pay codes constantly. Don't wait to just revalidation to update your Medicare, and make sure your service areas are right. People's service areas are still incorrect in PECOS. And now that we're doing county level data, guess what they're marrying and matching to? Okay, most people look at their ownership type correctly, but now they're going to be linking your enrollment to your national provider identification and then to the common working file, and which gives you all the Medicare enrollment data. And this is where you start differentiating who's Part B. So a Medicare person that elected to have Part B. And we know we're in the throes right now of Medicare replacement policies for 2025 and Medicare Advantage. This is where you find this Medicare Part C. So you're going to see them opine on some of the data, this transition that we've seen begin to happen. We're in that throes again. There's going to be some stuff, and I'm going to talk a lot about Medicare replacement this afternoon. What to expect as an industry, what should we be working on? There's some policy changes that we're going to really strongly advocate for to fix regulatory wise. We're in the height, as we know, a presidential election. So it's going to be very interesting what happens, and CMS at that time is going to determine different strategies. The one thing, and you can kind of read this when you get the PDF, it's really easy, but I just want to kind of go through a point. Basically, in your Medicare fee-for-service claims, they're giving you everything. Pay attention to how they use zip codes, okay? That's the area that we're going to work on because of the way they're lumping us in urban, rural, super rural is not necessarily where you're located. It's where you transport a patient. The interesting thing, though, it only incorporates to 5% of the market that bills hospital, is you do not bill origin and destination a hospital bill claim if you're Part A. So they do link your NPI to the hospital's practice location or the EMS practice location, okay? One thing to know, one thing that you should know, if you're billing Medicare to get denials in order for Medicaid to pay treatment in place, things like that, none of that is included in here. So if it was zero payment, if it was non-covered, if it wasn't associated with mileage and paid, they did not include it in the data. So just know that about the data. This is only claims that were paid. I'm making it for a reason. Because when you start seeing some of the data, people are like thinking, well, they probably denied that. They kicked it out. No, this is paid claims data. It means Medicare had a payment associated with it. And I'm saying that for a key reason, because it'll make sense to you when you see some of the slides that I show you where our problems are. Okay. This is the first thing that's alarming to everyone. All right. Medicare kind of alluded to it. MedPAC kind of alluded to it over the last year or two, but this is the first time we actually seen them publish what they consider to be volume providers. So you're a low volume provider if you if you build a Medicare fee-for-service program, 200 or less transports a year. You're a very high volume provider if you build a Medicare program more than 2,500 transports a year. That is very interesting. Okay, it's going to be a lot of people that are going to be associated as very high volume providers. That's problematic for the industry. That is never what we have defined ourselves as an industry. Like, and so when you get reports that come out, when we get MedPAC reports that come out, depending upon where you land, some of you are going to really like this, because guess what they're going to do? When you look at the MedPAC 2013 report, guess where they start strategically placing money? They're going to place more money to lower volume providers, and they're going to think the high volume providers, the data is showing by the NPI numbers, you're less likely to exit a market when you're a high volume provider. So what's the data painting? And then I look back and I see for 5 years, we have had relatively little change in who's billed the program. So people are entering and exiting the market, which we know the biggest part of that is going to be the for-profit companies that keep coming in and out. And if I'm going to target where money is, I'm going to go look at 2013. This is where I'm thinking people need to start opening their eyes with how we're defined here. Now, we don't agree with this. I'll tell you, a lot of people, there's a big issue. You got to start educating local, like, what does this really mean? If I'm a provider that does this and I'm in an area that I cover a lot of square miles, that's a big problem for you. And so we've got to educate here. So this is the reason why I'm bringing this up. This is problematic. And this is actually running through the system. I had a long conversation 2 weeks ago with the MedPAC commissioner who's he's free flowing in information. This is not new to EMS. This has happened in the ambulance surgery centers right now is going through this problem. We have physician practices that are going through this problem as well. And it's a way to kind of shrink policy to consolidate the market. They don't want it to be owned by everybody, but they think there's too many providers in the EMS community. So is there a way to kind of lump you, change policy correctly, and kind of maneuver it down the road? So others are already doing this and having a problem with that. Yeah.
A question for you though, Asbel, now this says annual Medicare ground transport, so if I'm understanding you right. This very high volume service is 2,500.
It'd be about 10, they bet 10,000 calls a year.
Total calls.
10,000 calls. Remember, this is Medicare fee for service. So I would say I'm 25 to 30%, depending upon what you are. Just for easy estimation, just quadruple the number. That would be what you would do annually. So if you're low volume, you might do 800 calls a year. Okay. All right. So some people will like it, some people won't. Depends on that, which of course is going to cause an issue in the ambulance community. And the best way to not have to do anything and solve policy is if the industry can't agree on something, like go figure it out and then come back to us. So that's usually an issue. So this is what industry just has to get around and kind of wrap their heads around. Here's where some of the data, you that like to get into it, remember your N number that you're looking at is how many NPI numbers are billing. Very low, relatively few changes. The only thing that really relatively changed at any insignificance was the ownership categories in the nonprofit sector to the government sector. Not much there. You're billing, if you're interested, we still have about 95% of everybody billing the program that are doing ambulance are the suppliers. You're a Part B provider. So relatively speaking, hospitals are not moving into the market. Okay. Some might be in, some people are like, well, they've called me or whatever, but you have been moving out and then moving in. Okay. Relatively little change on that piece of it as well. Most of it's going to be a scare tactic, or you might be in a certain area where a hospital's upset about something. They decided to go into the business. But for the most part, if you're looking at it nationally, not big changes there that are going on. This is where the data changes. So there's a lot of shift that happens. Very little shift is happening on the organizational side of it, but the volume sides are a ton of shifts. There is no correlation between the two. So when I start looking at transport and Medicare, this is what the data is starting to tell you. In 2017, in the Medicare fee-for-service program, the industry billed for 14.7 million transports. By 2022, they billed for 10.8. Now, this breaks it down by quarter on each of the pieces of it. Should be no surprises that COVID happened and we saw a major dip. That's no surprise to anyone. Of course, we did that. The end of 2022, you're still not back to the numbers relative that happened in January. Now, there's two reasons for that. One reason is Medicare Advantage. Okay, we know 50.5% of all Medicare beneficiaries have elected, and this was information that was published at the end of end of June of 2024. So 50.5% of the Medicare beneficiaries are in the Medicare Advantage. So pretty much half. Right? What does that look like? This is where we start to see disparity. This is why you're going down to the county level, because it's going to be interesting what the data continues to produce. The second thing that people have forgotten about is very interesting. They didn't catch it in the report. But if you do non-emergency and you did dialysis, when they rolled out the demonstration to be a nationwide model, it really, you can see the dip in the numbers in the stats. If you read the report, you can really see it. That's what that was related to. They didn't catch it at CMS, which was very interesting to me when they put the data out, but you see it very quickly. It's a change in that RSNAP model as well as the change and shift in Medicare Part B. Now, here is where we get into a little bit of the way they distributed the Medicare ground by NPI from remember those low volumes that we talked about to very high volumes? Shouldn't be surprised, but it looks like out of all of the transports of that 14.3 million, the low volume providers approximately do 70% of them. Okay. The other 30% are done by providers who typically bill the Medicare program yearly more than 800 transports a year. Okay. So that's kind of interesting. Well, let's talk about the shift in the Medicare penetration market. If you're in rural areas or super rural areas, you probably have seen very, very little change, very, very little change in Part B to Part C. And that's kind of a no-brainer because, of course, Medicare Advantage is administered by private insurance, and they're going to go to where the majority of the beneficiaries are. And they're going to try to convert. So it's no surprising. So if you're in an urban market or a higher volume market, you have seen a major shift. So for instance, if you're in Colorado Springs, more than likely, if you look at your numbers, you probably are starting to see a big shift from Part B to Part C claims as well. And so this is going to be really, really important as you kind of look through the data. Here is another slide that I want to kind of just talk about because this is the number one reason why I'm not out there talking about this nationally. This is a problem for us from a billing perspective. And because this is a finance meeting, I'm going to talk to you very briefly about billing. And if you don't know what I'm talking about, this is an area this is the reason why we're talking about it. And I'm going to give you some next steps that you should be doing through the process. This is the first time in 26 years that I've seen, specifically them actually release how we bill as an industry. Okay, so they're just giving you the top 10 ICD-10 codes that you use and bill claims. And they looked at the data and they said in 2017, these were the number of transports that the EMS industry did. This is the number of emergency transports they did. And these are the ICD-10 codes that they billed in non-emergency. This is non-emergency only right now. So A0426 and A0428, this is how you billed. And in 2022, these are the top 10s that you used in non-emergency. Now, no surprising in top 20 in the top 10 is the ESRD number that would have fallen under a prior authorization model. But notice some of the codes here. Some of us that do this all the time, you should never use M62.81 ever as an ICD-10 code to validate medical necessity for anything. And remember when I said this was paid claims? This is claims they paid. None of this is denied. So people are saying, well, they usually deny it if there's an edit for it. No, this is paid claims that come in from the MAC that Medicare pays for. This is not a Medicare Advantage program. There are codes that we're using here. Doesn't mean it doesn't meet medical necessity, but on its initial blush, if I'm a program integrity auditor, I am going to go audit everybody that uses these codes, is what I would do. Okay. And they keep doing it. This is an issue for us, and I'm going to watch and show you how it correlates to the Medicare recommendation that MedPAC made, not Medicare, but that MedPAC made in 2013, talking about this issue. Now let's talk about emergency. The numbers that I'm giving you as a black arrow key are the concerns that we have. It doesn't necessarily mean that it didn't meet medical necessity. There are some initiatives that we want to do around what do we do moving forward around the definition section. So if you've heard, we spent a lot of time in definitions on the Ground Ambulance Patient Billing Advisory Committee. There was a reason for that. Because there's general sentiment, if somebody calls 911 and you respond, that there should be payment for it. Unanimous vote on that. I think it's very, very important. It may contradict some of the things that we think internally, but they think and correlate it very similar to ER physicians. You know, if somebody goes into the ER and they get seen, they're going to pay them. It might be a smaller amount versus a different level. You have 5 different levels of service, but they're still going to get paid. Same concept, they're not penalizing the individual. So there's a reason why we did that. Very unanimous support on that. The health plans got it. The data from NMSIS actually worked for us because it showed very small percentages in the NMSIS data. So there's a lot of different things that we can use to conduit for that, Tim.
So as well, a little confused, even when you refer to the ICD-10 codes, we're used to billing for BLS emergency, ALS, mileage, those codes. Are these ICD-10 codes that you're specifically referring to is what we're using for our medical necessity?
So these are the codes. So let's just make this really simple. Don't even think about medical necessity. Make this really simple. This is the claim. You're coding a claim, and you can put multiple ICD-10 codes on a claim. This is the number one position you put that ICD-10 code. and you transmit that claim over to Medicare, they now have the data. They took that data and they said, give me the top 10 that were used for this volume. And these are the top 10 codes that were used in emergency for EMS across the board for 8.8 million bills that they paid for in 2017. Your number one code used was shortness of breath. Okay. Your number two code was chest pain unspecified. Your number three code was altered mental status unspecified. Your number four code was weakness. These are the top 10 codes if I looked at 8.8 million transactions. Okay.
And so would this correlate to a term like clinical impression? We're just putting in the impressions.
Could be a clinical, it's whatever. Here's my sample. It could be a clinical impression. It could be something in your documentation that you wrote when the medic was scrolling and saying, we wrote, this is what we did. They were complaining of shortness of breath or something like that. And then we have EPCRs that sometimes will give you suggested ICD-10 codes, or we have billing agencies or internal billing places that might be using artificial intelligence to assign ICD-10 codes. Or you've got the manual thing where somebody just said, oh, I know this code pays. So, oh, you see weakness, I know it pays, assign the code. Okay. And so it could be any of that piece that's happening from an operational design to a billing design. I'm going to make a recommendation, because how many people do their own billing in here? We got a few. And how many outsource? Probably half of it. Okay, I'm going to give you an out, because now you have some of the guideline. It's going to give you some compliance and how do we risk mitigate this. But these are some of the things. It doesn't mean that this code is that if they audited you, they would still not determine medical necessity, medical reasonableness for the 911 call. What it's saying is it could trigger an audit for you, and now I'm going to be audited. And we always know when we get audited on something, they might not get you on the ICD-10 code, but they're going to get you because you didn't get a signature. And now I have hope. Does that make sense? This is the last piece that I want to kind of tease for you guys, that what we need to pay attention to. And this is the MedPAC report that came out in 2013. So 11 years ago, this was released to Congress. The industry had it. I'm advising everybody to dust it back off again. This is the thing that I'm going to be going back to you in December. I will kind of take the industry through what you need to pay attention to as the data starts to come out. But remember, in 7-1, they gave us two different, and this is the summary side of it. There's a lot of detail that goes into it. But they said Congress should first allow the 3 temporary ambulance add-on policies to expire. So we know at the end of this year, they're expiring unless the add-on gets renewed, which that's an interesting. It will get renewed, but whether it happens at the end of the year remains to be seen. Whether we're going to get a plus up or not, I don't see that happening. Just so you know. Direct to the secretary to rebalance the RVUs, or the relative value units, for ambulance services. So what that means is, should we pay ALS emergency more than BLS non-emergency? Okay. Or look at the geographic. Maybe we've assigned too much to Denver and we should have given more to Colorado Springs. Okay. So when they're saying we're going to rebalance the RVUs, we're going to look at the geographic pricing index. We're going to look at different things. And that's what their recommendation was. The third bullet point was they wanted to direct the secretary to replace the permanent rural super mileage. So you still have a differentiation between the first 17 miles. If you're in a rural zip code, you get paid a different. They want to change that and replace it with a permanent one. Okay, so they agreed that we should make that permanent. Don't get rid of it. Make that permanent. However, get the money and make it budget neutral. Okay, so budget neutral, we're not giving you more money. We're going to make you get that budget neutral for that permanency somewhere else. What are they telling you? We need to have targeted reimbursement. Where are you going to take it from? You're going to take it from, if you read through it, non-emergency areas, because look at number 2. Congress should promulgate national to more in medical necessity requirements for both emergency and non-emergency, recurring and non-recurring ground ambulance transport services. So I want to go back to what we actually defined in the Ground Ambulance Patient Billing Advisory Committee. We enhanced the definition of what a prudent layperson's definition of an emergency would be. We talked about in emergency interfacility transfer, specifically from tier 3, tier 4 hospitals that were going to tier 1s and tier 2s. But these need to be an extenuating circumstance. Should that just be a continuation of an emergency? We have some people that bill those differently if it's the 8 hours later or 12 hours later. And there's some rural communities that sometimes it takes them a while to find that bed to get an ambulance there to take them through. And so some people would bill those as non-emergency. A lot of confusion in that area. But notice what they asked and recommended to Congress in 2013. All right. Then they said develop a set of standard national edits to be used on all claim processors to identify geographic areas where ambulance and suppliers display aberrant patterns for use in statutory authority to address clinical inappropriate use of basic life support non-emergency ground ambulance transport. This is the picture they are starting to paint on the ICD-10 codes that are used. So if I'm now looking, I've got data, and wait till we get the second round of data, kind of that starts talking about cost. Start looking at geographic areas. Let me go look and see in the state of Colorado, we have all the zip codes now. So I can say, like, these NPIs that do this, NPIs that do this, so look at how they're billing the system. So now maybe I'll have a top 10 ICD-10 codes that are being used for Colorado providers. Now you have data. The one reason why these recommendations were not adopted outside of one recommendation they made, and that was to do something about dialysis, and we know they did. We had the RSNAP model. They reduced, the dialysis transports by 10% to try to get rid of some of that. There's a lot of stuff that was happening on that piece of it, but they didn't recommend any of this because several of this, I was one of them, said you can't use anecdotal data to come up with these recommendations. There could be all these issues that happen in service delivery models across the nation. Now they have data. Now it is not anecdotal anymore. And so we're either going to have to say the data is junk because people didn't know what they were putting in, which that very well can be. And we have to be able to prove that it's junk. So what's the difference? We have GMT cost reports that we know have now been overinflated. Those numbers were overinflated by the use of the CPEs and the GMT in certain states because the OIG did their piece of it and found out, oh, you're including costs that are not direct patient care. So your numbers are overinflated. And then they're going to compare them to what we have right now. Well, some of us kind of know what the data is already starting to show. And so we know that the government, to nobody's surprise, has higher costs than their for-profit counterparts. Their for-profit counterparts seem to be more efficient. But here's the general narrative that's painted there. That doesn't really matter to me, because to be honest with you, it's not really about cost. It's for-profits generally, and this is not EMS, this is healthcare in general. Generally, the sentiment is they will cherry pick. Think freestanding EDs. Big issue with freestanding EDs. They would set up their offices in areas where they knew there was higher insurance and less Medicaid. Okay, so they cherry pick the markets. Of course, it would be more efficient. You have higher rates here, lower rates here, than those that are servicing community. But they've also begun to draw the correlation that those that serve the under and underserved are using it to enhance their Medicaid financing. And so we're starting to see some of that. And we see articles about it. We see articles about it in EMS right now that's happening, where they're like, oh, you should go do that. You're in here, you should raise your rate to here. And so by our own admittance, we are actually validating some of the data that's starting to come out. And it might be for a totally different reason, but we're using that piece of it. And so we no longer have the window anymore. And I feel like I was presenting this last week as well. I'm like, I feel like a doomsday preacher. I'm really just giving you real talk right now, because there's a lot of other stuff, but it's saying some of our talking points that we've been using, we've got to now understand they worked for us when the data was anecdotal. It doesn't work for us when now we have data here. So the only other thing we can try to do is disprove the data as being junk. That's the only literally thing that we're going to be able to do. The problem is, we know that we have some exposure on the GMT programs where cost data has been happening. And we know now we have similar data that's going to come over here. So they're going to remove out the outliers, which they're already doing. Like there's going to be people that put junk in there. And if it looks like junk, they just remove the outliers. And where do we handle in the middle? Okay. When the GAO did this report, when they sampled the individuals, they sampled the 200 largest providers in the nation in 2013. Okay. And that was a thing. Well, the periphery wasn't there. How do we deal with rural? And these are the analogies they came up with. And so, generally speaking, if you start looking at that, and then you start going back here, and so I'm just diving deep into the report and their assumptions because I'm like, oh, this is what they're doing here. And so you can start to see the narrative and the picture that they're beginning to paint. We will have to answer the question as an industry, not some people are going to love it and some people are not, because it was a big point of contention at the Ground Ambulance Patient Billing Committee in subcommittees. And this was, should 911, should emergency be a utility model? Should it be funded and work a lot like water does, electrical grids, fire, police? So should there be lump funding that happens based upon that, and then kind of let the markets dictate the cost thing with that? That's going to be a real thing. That has come up already at MedPAC. The MedPAC commissioners, with the staff, like, should there be a recommendation to really talk about that? We heard that at the at the Ground Ambulance Patient Billing Advisory Committee. We heard the Brookings Institute actually bring it up. We've heard the patient advocates keep talking about it. And we in our own industry, some of us like it, some of us don't. And so in our own industry, we have people saying that's what should happen. Every transport should be funded. We should have an allocated funding model to that. And then you have some that they don't like it. And so whenever you start getting that piece of it where the industry doesn't align, then the periphery and the data make the decisions. Okay. This is what happened to us in negotiated rulemaking, folks. So when they put the negotiated rulemaking fee in, it got implemented in 2002. California got upset. Massachusetts got upset. Others got upset. And that's how our 2, 3, and 22.6% started. Because then they got on the hill and they're like, well, let's temporarily give them so they can manage through this process. It was an interchange. You could see something similar happening, similar kind of playbook that's going on right now. But the one thing that you didn't have back during negotiated rulemaking was this shift from Medicare Part B to Medicare Part C. And you see a lot of analysis being done on that right now. And there's a reason for that. So this is pretty bipartisan, that they'd like to privatize as much of the Medicare space as possible because it gives them budget surety. But we have this stuff, and I'm going to talk through some of the things that we need to pay attention to. It's kind of interesting how some resets are happening. Kind of interesting where certain people are now being hired by certain people that were either in government before. They're now working for payers. They used to be on the provider side. There's a picture being painted. The former CMS administrator under Trump's now working for a Medicare Advantage program. There's a lot of these things starting to happen. And it's like, we see what's going on. They lost a lot of their bonus payments to do something they're going to take away. It's going to impact the EMS industry. I'm going to talk a lot about this. But this is the area where history is going to tell you something. Pay attention to the MedPAC report. Pay attention to what we have going on in data. Now, I've kind of did that. So what do we do? So what do we do as an industry? Now that we kind of know things are starting to happen, we're going to do this again as soon as the next CMS data rolls out. Okay, what do we prepare for now? There's going to probably be some aha moments for people too. There's going to be some people say, oh, I knew that was going on, which we already know. You know what I'm saying? So what's it paint? What's it look like in the rural, super rural areas? These are a few things that I would strongly suggest you pay attention to. Everybody keeps talking about finances. Unless you just have a budget and a tax subsidy that definitely pays for you. To our friends Rob Lucas in Austin, they really don't have to worry about them. You know, it's free flowing. The money's free flowing for them. Have you assessed your Medicare Part B to Medicare Part C utilization? You need to know what that is. If you're in the rural, super rural areas of jurisdiction, there's probably not a lot of shifts for you. But if you're in more markets, I would say that do more 50,000 to 100,000 population mix, then you probably want to pay attention. It's probably just a few of the markets here in Colorado, but pay attention to that. You also need to manage what your out-of-pockets are doing. This is really, really important. This is going to be a policy initiative that you probably can win as an industry. This is an area that we do know there has been a big shift. I'll talk a little bit about that. How do we get that fixed? But unfortunately, it's like essential services until COVID hit. We realized, oh God, we're not an essential service because they're not giving us PPE. And so everybody went out, so we should be just like everybody, house fire getting PPE before we're getting PPE. If you're not on the same list as an essential service. This is the same thing, the definitions. There's a reason why we made several definitions, and people are like, why are you making a definition to be an essential health benefit? Because technically, you really aren't. Technically, emergency medical services, 911 doesn't have to be covered by insurers. They could actually omit it and don't have to pay. Now, would they do it? It's kind of funny. Sure, it probably wouldn't be publicly popular to do that. But when people get crunched on budgets and money, they might do it to just prove a point to Congress to stop doing that. So then you become a political pawn. But technically, they could actually write you out of coverage policies if they wanted to, because you're not an essential benefit that has to be covered. Here's the third thing that everybody has to do. We're not doing this well enough. And this is, we have got to analyze the way that we code claims. Now, this is going to be very controversial, what I'm about to say here. I think we've conditioned our industry incorrectly, and we're starting to see it now. And that means if in hospital industries, physician industries, they require you to have a certification level to code claims for the most part. You have to be what we call a CPC, a certified professional coder. All right. That is different than in the ambulance industry, a creation of the certified ambulance coder. It's very needed. It gives you a grounding of what happens, but it doesn't really teach you how to use ICD-10 codes appropriately. CPC requires it. There's a certification, there's a testing level. Think like you're going to go through an EMT course. You're a paramedic, you're going to have to test all of this. You got to go through a whole certification process in order to be certified as a paramedic. You see it in the data that that's the problem. People don't really understand that. In the vertical that I operate, I have some different stuff. We require everybody that does project management. I'm not a billing agency, but if you run into a problem, I can help you get caught up or whatever. We require all of our coders to be CPC for a certain reason. And this is the reason, because they know you would never use some of these codes that people are using. It just is not required. And oftentimes the ones that are doing that, even when I was at Acadian or running Acadian billing office, we required them to have certain certifications on the coding side. And so this is an area that I think has been exposed in this piece of it that we have got to fix as an industry. We have got to have a certification course very similar to EMTs and paramedics related to ICD-10, and it has to be almost like you conduct an EMT certification. And they have to test, they have to know how to apply codes, and they have to have a renewal every year for it. This will fix that problem. Okay, so if they do, it's not that they're unknowingly doing it. Then you move into what the provider communities or the physician communities get, where fraudulent billing is really happening. They know what to apply. They're just misapplying and upcoding and doing things they probably shouldn't be doing. All right. Number 4 is, do you have an external agent company auditing your current processes? That's very key from a risk standpoint. If you're a billing agency, strongly suggest you're using someone to come in behind you. And there's a lot of these firms out there doing it. They're going to give you an assessment. They're going to tell you what to do. They're going to let you know, because this is going to become problematic depending upon where you are. I'm hoping on the emergency side that I'd love medical necessity to go out the door. Like, it doesn't really matter. Your Medicare beneficiary called 911. I'm taking it and getting paid for it. Tell your Medicare beneficiary to call. You know what I'm saying? Same thing with insurers. Like, to me, we did that. They don't do this to CVS. We've been saying this all day long. I need to have a prescription. The doctor wrote me one. I go to CVS, they fill it. If the doctors are erroneously given prescriptions for it, they don't go after the patient, and they don't go after the CVS for it. They go after the doctor, and the doctor loses their license. That should be the same concept that's happening with us on the 911 sets. I will tell you, generally speaking, when we went through the data, and I know there's a lot of issues with the NMSIS data, but the NMSIS data actually supports our point right now. And when they list and what you guys are sending back to them shows, when you look at the elements that are happening and the behavioral health responses and the reasons why, I will tell you the health insurance plans, the Department of Labor, the Department of Treasury, the Department of Health and Human Services, the Brookings Institute, everybody else, we're like, why aren't we paying for that? It's the reason why there was a unanimous, like, response to transfer should be paid for. What they didn't understand, and that's a whole balanced billing committee concern, what they really didn't understand was community paramedicine treatment in place. And I know Matt spoke a lot about that. There's a reason why it's in a finding. Those went to a finding very quickly because it got controversial. They didn't understand it. And this is the reason why, Tim, I know you asked me last night, like not allowing it on the committee. If it can't be unanimous and people can't understand it, they can't understand it, move it to the side to a finding. There's also a reason why you see a finding on the establishment of a standing committee. That's where all that stuff has to be vetted. And the stuff would need to be vetted on stuff that CMS could do or a standing committee. And they have these standing committees that meet constantly. FDA does a lot of this. There's a new drug coming into the market. There's a standing committee that makes a recommendation that this could be a regulatory change or a policy change versus us using the political arena for it. And then our own industry doesn't agree with it. And so they counteract what you're doing at the local level because they're doing something else that's telling you something different. And that's the one thing that I've learned over the last 4 years working in this space outside of the confines of an ambulance service and going into a lot is we're all there. Unfortunately, we lie to each other and we're not being honest. And we say we're not doing something and we're doing it. And I see it. And I was just sitting here and I'm not saying they just lied. They know what they're doing. Because you see it. Do you know what I'm saying? But my standpoint, I say pretty neutral on it. But the problem is now is coming out in data. It's the whole reason for the transparency rules that started in the Trump administration. This was the provider transparency. So think hospital transparency. They have the providers, you go underneath it. Then you have the insurance transparency side. This is the payer transparency side that we're starting to see. And they believe that if you can be transparent about the charges, the in-network agreements, the stuff that's covered, we wouldn't be having this No Surprises Act issue that's going on right now. Okay. So if you think more of that, you're starting to see this administration moved a little slower on the, not the execution of it, but the implementation as well as the accountability metrics. They've not been finding the hospitals appropriately, rolling it out to the providers to be more transparent, requiring them to do it, as well as the payers, but you're starting to see the more punitive results starting to give. You can guarantee yourself what will happen in the administration. So if Trump takes office, pretty much expect him to do what he did in the first piece. So he's going to go more to transparency. He's going to do more of that, and he's going to want to throw everybody into Medicare. That's a given. If Kamala becomes it, he can probably sleptwalk it a bit more. Usually, technically, an administration that falls under the Democratic philosophies are probably a little better for healthcare, especially those that deal a lot in the entitlement systems. And it's probably going to be a little bit more. So where you stand politics, I don't really care. My standpoint is just understand what you're going to be preparing yourself for and how is it going to align with the data that's coming out. Is there things that we move regulatory? Is there some things that we're going to be able to move congressionally? Or are we just going to be in this limbo talking about this 4 years from now? Like we've been doing, and many of us, I know Matt's been talking around kind of where we might just be just from an anecdotal standpoint, or is there really going to be some fundamental change? I'm cautiously optimistic, guys, that the data is going to produce some change. We're either going to like it, some in the industry are going to like it, some are not going to like it, just as a matter of fact, because it means I might have to change. I might have to change the way we do business a little bit, okay? My number 5 is, are you really getting the trusted guidance from your RCM partners? Some of the stuff that we're getting out here is the same way I feel about EMS. Sometimes we have way too many billing agencies. Sometimes we have way too many small mom and pops that are doing billing and they're not following the process correctly. They're just seeing, I need to get paid. I need to pay. I use that code, get paid. Not necessarily being. So now that the data is out here, this is the same thing that we see with a lot of other stuff. So really, I think we need to kind of up and ante the game. That's kind of my responsibility now. Going to go around and start saying, this is what the data is going to start to expose. And unfortunately, it's probably going to get a little more painful before it gets better. It's some of the stuff that we're trying to counteract. Yes, sir.
So if I wanted to find an external agent to come and audit my current process, do I just call 1-800 external agent? Where do you find those external agents?
So unfortunately, there are several that do that. There's several that do that. There's not a lot that do that, but because I'm here presenting, guess what? That's what Solutions Group does. That's also what Nat's firm does at PWW. They'll come in there and do a thing. But what you have to do is make sure you're doing a comprehensive reimbursement side, not an overview. There are some out there giving you just a very 50,000 foot view. You need somebody to come in and say, I'm going into it through the life of the claim. And I'm going to tell you, this is where your issue is. This is what's going on here. Because I'm talking to me and this is what is going on there. We do have something called Insight. It's an audit tool that looks at 23 different critical elements. And you can run the claim through 23 different critical elements and it will score you. It's patent pending. There's a lot of emergency EMS systems that we're doing it with right now. And so it's a system and it will run your claim through and it will give you a score. And it will tell you you're at 89%. And it's only on the reimbursement side. And it will give you why you failed something, ICD-10 code was used incorrectly, things like that.
Just curious, for a larger Medicare provider, around 800, 100 plus, how much for that monthly? Are you coming to do that out of?
It depends on what you do monthly if you come in to do an entire piece of it. If you do the 23 critical element that I'm talking about now, you can probably do it for about $6,000 a year.
Okay, are those generally tied to OIG compliance programs as well, or is it like a separate?
What do you mean?
Well, like I know hers also purveyors out there who will sell you the OIG compliance program.
So here's the difference between the OIG compliance program and having somebody audit if you're billing a claim correctly. Okay, OIG has that compliance program is totally different. To me, that you're working and putting a compliance program in. Am I auditing my record from the life of a claim? So you need somebody that understands the reimbursement side. Did you code the claim correctly? Did you use the appropriate ICD-10 code? Did you use the appropriate HCPCS code? Did it get paid quickly? How long did it take you to get the claim out the door? Did it deny? Was there a first pass denial, second pass denial? You're going to go through that process and figure out, did you write a claim off incorrectly? Did it deny for timely filing? Are you in an area where we write off all copays? Well, maybe they didn't file the claim. They just wrote everything off because you had whatever, and you don't even realize that happened because all you see is, well, they increased my cash for transport another $10. So you're happy about that. But what if it could have been increased by another $100? But you don't know that because you're only looking at cash reports. So if you are a reimbursement or you're looking at it only from my cash increasing, I would strongly suggest you get somebody outside looking at your processes. So if all you do is manage how much money comes in the door, you can almost probably guarantee you're leaving money on the table, or you might have some compliance risk as well. But that will kind of do it. It's different than the OIG compliance program. Everybody needs that. So that's a whole other construct. And there are some great firms out there that do that do those OIG compliance programs. The next thing that I'm going to say is audits. I would fully expect if I do non-emergency right now, audits are coming again to you, and it would just make sense. This happened to us in 2013 when the Medicare report came out. All of a sudden, there was a proliferation of audits that started to happen. Now that the data is coming, it's only a matter of time before a program integrity audit contractor gets in here. If I did that, it was not a conflict for me. I'm like thinking, I should go be a program integrity audit. I can get 18% of whatever I recover, and I can see the code that they're using, and I'm like, I'm going to go after and get them. Does that make sense? But I wouldn't do that. Do you know what I'm saying? So the point is, they're going to catch it. If you're doing non-emergency, fix that. If you're emergency versus non-emergency, these are public policy initiatives. This is stuff you can actually do here in the state. And in the state of Colorado, start making sure I go back and relook at my definitions of what an emergency is. I might need to start that work now. Pay attention to the prudent layperson's definition that was recommended unanimously in the Ground Ambulance Patient Billing Advisory Committee. Follows a lot of the similar sentiments of California. It's actually a really good. It actually does not allow for a retrospective review. Okay, so if it is at the condition there, you can't have an audit that would happen on an emergency code and they retrospectively try to come and take it back. So it's actually a really good. There's also some other stuff that's been happening around emergency, specifically in Medicaid. The state of Nevada has a pretty fantastic Medicaid definition that we're trying to get CMS to adopt right now, especially on the Medicaid financing side. And this is scheduled versus unscheduled. We talked a little bit about this on the Ground Ambulance Patient Billing Advisory under a subcommittee, and they couldn't wrap their heads around it, and our own industry couldn't. So I had to shut it down a little bit because they just couldn't understand what we were trying to get at. And we were spending too much time on it. So we settled for the interfacility emergency medical transport. But technically, your costs are no different if you're picking a patient up out of the ED to take them somewhere else because they need to be moved usually within an hour or two. Okay, you've got to have the same cost of readiness. You got to, not like you can call on a new shift, come in, how long can you get there, especially if you're in a rural area. Your costs are very similar. So the state of Nevada got a definition approved back in 2016 on a scheduled emergency transport. Pretty fantastic. Pretty much, I'm being vague here, there's a lot that goes through. But basically, if a transport is scheduled in less than 48 hours, you would bill to Nevada Medicaid a discharge to a nursing home as an emergency. Okay, so there's some different things there that you could kind of work through the system to say, should we be looking at certain public policy initiatives? This might help, this might work in some states, it might not work in others. We're working on some of these initiatives. There's also some patient-centered reforms you need to start paying attention to. And this is the one thing that our industry needs to pay very, very close attention to. This has come up over the last few years because of the insurance carriers talking about, oh, we only want to pay you this much. And they change the benefit, they raise a deductible or whatever. And we're the provider, the patient agreed to have $1,000 deductible. Okay, so you've got emergency physicians right now floating a bill to put it on the insurers to collect on their deductibles. The problem that you're going to have there, and this is one thing that we're talking about, this is an area that the gentleman that works for one of the third largest ER physician staffing company in the nation, that he pretty much started a association outside of the Emergency College of Emergency Physicians, ACEP, called EDPMA, Emergency Department Practice Management Association. And they have been working very concertedly on why it sounds good, what are the negatives to it? And there's probably more negatives right now of trying to put a spin and introduce a bill to try to stick it to the insurers. And that's what most people want to do. Let's stick it to them. Why are they giving us and then I have to go after and do it? Problem can be problematic and blow up. Because then what happens is you stick it to them so I can get first dollar claim. They assign $1,000 deductible. But what if they don't go after their beneficiary for the $1,000 deductible? How do you get paid for it? You know, what are those nuances that you need to start working through? Is there a way that we can beat the insurance lobby on saying if that happens, then what happens here? So there's a lot of negative, or are we going to see more Optum moving into the market and just saying, well, we'll just come in and control it all? Which that's very real, very real. It's going to happen. Payers kind of, you're starting to see all the synergies happening with home health, and Optum's buying out a lot of people right now to kind of look at it. We're just waiting to see when that happens in the ambulance industry. Public-private synergies. See more and more of that. It's going to really come out. So if I'm in a for-profit company, I'm looking at what's going to happen on this 911 side of things. Your market dynamics, your out-of-pocket reforms, pay attention to what is happening in other states around that. Medical debt is being looked at. People should pay very close attention to what's passing in the state of New York. And if I'm a fellow, this is where blue and red come in really importantly. So if you're in a more blue state, you should probably pay attention to what California, New York, and Washington and all of them are doing, because that could have an impact on what happens. And the one thing that we are seeing is medical debt. No longer in the state of New York can you report any medical debt. I don't care what the dollar value is. Okay, there's none. There's no incentive at all. State of California for EMS, as we know, if you're uninsured, you can only bill a patient up to the Medicare level or a non-covered service. So they might be insured, but a service isn't covered anymore. So, and it's only Medicare. But other than that, I have to pay the local rate that you say, or let's just say for here, $325 on Medicare. Well, if I'm the insured, thinking I might be able to not cover that benefit, and I'm only going to wind up because they just passed the state law. So there's some unintended we're watching California very closely to see if anything changes around benefit design that they have to approve it in terms of 2025 or 2026. So those are little areas that might seem benign at first. Now, granted, the California ambulance providers were not behind that initiative. That was a patient advocate initiative, but people are paying attention to it. It makes sense. And it's kind of bipartisan. And things like that. So it's very interesting as we work through this, what's going to happen. I think I've got a scan here. I know you're going to be sending that out, but feel free to download this as well. And if you've got questions, you can actually you can email me as well. And then I'll stop here and see if you guys have any questions. I know I gave you a lot of data. I'm trying not to be Debbie Downer, but at the very end to kind of tell you those things that we can do and work through the process. We're gonna have to pivot. Key points that we've been using for the last 13, 14 years is gonna pivot with the data. There's no other way around it, at this point. So we're gonna have to change some of the way that we nomenclature. It's kind of because people get confused. What's your low hanging fruit? Your low hanging fruit, in my opinion, I would bet my career on probably in the next 18 months. We will see Medicare paid ambulance responsive transport. Ambulance responsive transport, not to be confused with what you guys call treatment claims. So if you call 911, your ambulance rolls, you get on scene. I will almost bet dollars for days that's going to be paid by the Medicare program. So, any questions?
I have a couple for you
Yeah,
as well. So I think you showed a declining trend line in total claims. So when, I'm just curious, when we talk about budget neutral in recommendation, the pie is shrinking, so budget neutrality is a smaller number is what I thought I saw there. Would you say that?
So remember that was 2013 when the NetPAC report came out of the budget neutrality provision. That was 11 years ago. A lot has changed in 11 years, specifically Medicare Advantage. Whenever Congress is going to opine on this and they're going to look at the numbers, they're only going to look at the Medicare fee-for-service numbers. I would strongly doubt that there's going to be a budget neutrality provision. I don't see that will be a big issue for the industry. I personally don't see it, but they will address this from the That's why they keep bringing in Medicare Advantage. That this, I think it could be targeted, a little more geographically targeted. Where I think urban rates that have a higher Medicare Advantage percentage, they might say, you know what, if you're in this geographic area, this RVU is going to change. So these GPCs, which is the Geographic Productivity Consumer Index, the GPC will change in some markets. It might go lower than what it is right now and increase in a rural, super rural market. That would make sense to me. Like logically, if I'm working on the government side and I was going to be doing this for ambulance, that's what I would start doing. I would start saying, okay, the data's going to tell me this. This is what it's going to go to here. The problem is we don't contract. All right. So what happens in No Surprises, most of the times you're not contracting. That solution works if you think private goes out and they contract for Medicare Advantage. And when I talk about Medicare Advantage this afternoon, I'm going to go through a lot with you guys so you understand how Medicare Advantage works. The context we have to change to the federal government is EMS doesn't do what other healthcare providers do with Medicare Advantage. So to that point, we can't use the budget neutrality provision. You're going to have to use Medicare Advantage data within anything that we do from that standpoint. I do think that's a counter that we can use to this data, that this is fee for service only, but you're starting to see them tease out the Medicare Advantage. So they're already looking at Medicare Advantage because they know that's probably anticipating an argument might be. And so we already see them looking at it. So you can see it in this first dash piece. That's why they talked a lot about. There is a lot of information in that data piece around the Medicare Advantage piece of it as well.
And then that ICD-10 coding, the problematic ones, just curious, are you kind of following that over time? And I'm just thinking of it from the perspective of everybody attempts to game the system to their advantage. So those codes will exist for a period of years until somebody catches on to them, and then another series of codes will pop up until somebody figures them out.
Typically, our behavior will dictate that. That happens. That's what's been happening in the emergency physician space. This is the reason that why they went through all of the cuts. Why they're not getting the cuts is because there was the proliferation where they were able to show in the data that the majority of the ER CPT codes that were used was the highest single code. Do you know what I'm saying? But the ICD-10 didn't compare to billing that code. And so now they're having to go back, they're having to reprocess their systems. What are they doing differently? Now they've got different clinical things put into place now that's saying, oh no, you're now training people, you're training ER physicians to do this and this, so you can continue to bill that code when you should be billing appropriately. So that's why it's very interesting in 2013 when they indicated we need to look at more clinically appropriate, but they only tied it to BLS non-emergency running. I think that's important for us to know. Remember, this isn't covering pass-through payments. the blood stuff that y'all have been working on regulatory wise, which really doesn't have a reimbursement impact for you for the most part. Those type of things don't really impact um, what the recommendations will probably be from MedPAC. We may see them talk about that. Really would be outside their purview to opine, but that doesn't mean MedPAC hasn't done that before. Any other questions?
So I'm remembering back to the lecture you gave probably, I think it's probably 4 years, it's pre-COVID. Several years ago, different building. Always kind of a big fan, actually. But I remember at that point you were talking about Medicaid or Medicare cost reporting as it was coming up, it was coming to fruition. You guys had set out some guidelines and recommendations. And my first question is the 50% reporting, the warning sign or the warning story that you gave us was look what's happening to home health care. And we've seen home health care completely decimated by their own design because they didn't take Medicaid cost reporting seriously. So my question based on that is that 50% compliance rate in getting the reporting done, how does that relate to the numbers that we saw come out of?
Here's what we've always been nervous about as an industry, was that history would repeat itself, but in our organization. And that's all that I can say is going to happen here. Here's the thing that I'm not seeing generally that you hear on the home health side is the focus really hasn't been more about cost. Whenever you're talking to CMS, I have a lot of friends, I never hear cost a lot. You know what I hear the most? Transparency, and they hate private equity. That is literally all of it. And to some people, if you're private equity backed, you don't like those words. It just is what it is. It's okay. There's good private equity. There's bad private equity, just like there's good ambulance services and then there's bad ambulance services. It doesn't mean private equity is bad. It's just they feel that they have run and they believe the data is going to show that. Now what they're showing in the data is there are higher costs in government, but that's no surprise because technically the G&T report showed that. You know what I'm saying? Even though they were using stuff that was not direct patient care, but even if you took that out, it's still going to be a higher cost, okay? It's showing for-profits are much more efficient, nonprofits in between, okay? If I'm looking at it from that perspective, there's one thing that I would want to try to do if I'm going to phase this in. Phase one is I want to get everybody to transparency. Who is not transparent right now? Can't get your information. I want to know what all your administrative costs are. I want to know what you're using for direct patient care. There's one group of providers you technically can't get that from. Okay? Nonprofits, you sort of can through 990 filings. Government, you absolutely can. So if I'm looking at this and I want to move to transparency, I'm going to start looking and seeing, is there a way that I can paint the data appropriately? Doesn't mean I advocate for one way or the other. Those people know I come from the for-profit side. So it doesn't really, like, that's been the window but I understand what they're thinking right now. If I want to level set on transparency. Then when I get to transparency, I'm going to level set on cost. You know what I'm saying? So I'm going to then look and say, I'm going to go after cost. They did this to the hospitals. This is not a new playbook. So this was a thing that I was talking to the MedPAC commissioner, and I was like, man, I can't believe they did it. They said, Asbel, this is not a new playbook. This playbook has not been used. Not like ambulance hasn't been fixed. You're just under the crosshairs now. The issue is this has been going on. ASCs are having this major problem right now. There's a reason why physicians took a major cut. They got this, whatever. They can't even hardly keep up. They're basically able to maintain this 2% so they don't keep getting another one. They're not getting any new money. Home health, same way. Not getting any new money. They just had to take another cut.
Yeah.
You know what I'm saying? That's the problem. So that's what I think is going to generally happen here. I think it's more than likely going to be a budget neutrality position that will include Medicare Advantage to keep it around that 5.26 billion. If I was going to bet dollars for donuts on this, though I'm off the record on this, I'm just giving you what I think. Doesn't mean that the industry isn't going to find on something else. I would think I'm going to put more money in the emergency side of the markets, into rural super to cover some of those areas. I may redesign deserts to allow for some critical access hospital type stuff that's going on right now in demonstrations. We do know that CMS has hired another academic institution to really look at the majority of the rural, super rural. So they're in that process right now. So there's stuff they've seen in the data that we as an industry don't yet have privy to. So there's a reason why you're seeing all this stuff happening around the rural side. The urban markets are not showing access issues, just so you know. We keep saying it. We keep championing it. It's a great talking point. Urban areas do not have access issues. And you only get money when you have access issues. And that's the best thing that you can probably see about all of this when you start seeing the data. So what I'm telling you, you better start changing your talking points. Doesn't mean, and this is the whole reason why I've said, Medicare should pay a fair margin. For the most part, they do understand and believe we have to give something. There's a great presentation I did. I should have showed it to you guys. What do we have? Are we done? Am I at the pass? I'm sorry. There is another thing that I need to, oh Lord, you got me taking a wrong point. I'll stop. Thank you guys.